can somebody comment in the comment section that I'm audible and the screen is visible?
Yes, sir, you are audible and the screen is visible.
Okay, thank you. So we'll start now. So today's class is on acute leukemias, which are one of the commonest cancers seen in hematology practice. So in this seminar, we will see about the basic pathogenesis of acute leukemias, and then the classification of acute leukemias. Then we will try to understand how we diagnose acute leukemias in the laboratory. We will learn about the various tests that we do in the lab, starting from the basic morphology, and then the other special tests which we do to classify and prognosticate this group of disorders. Then we will talk deeply about the treatment, and then we will end the class. So it's a very broad topic. We will touch upon the important aspects. So if you want to ask anything, you can comment in the comment section or chat section, or you can unmute yourself and then you can ask a couple of quick questions. So I need you to give some attention because we have a case study also today afternoon based on this. And the cases and pictures have been taken from today's seminar. So what is this acute leukemia? It is a type of blood cancer or hematological malignancy. So where does it come from? How does it arise? So these are cancers arising from the bone marrow. So bone marrow, there are different types of cells. There are cells which belong to the red blood cell lineage. There are cells which belong to the white blood cell lineage. There are cells which belong to the platelet lineage. So these are the three main common type of cells in the peripheral blood. And all of this arise from the precursor cells in the bone marrow. So this acute leukemia, it arises from the, or it is a cancer of the progenitor cell. So what do we call this cell? We call this cell as a hematopoietic stem cell. Why stem cell? Because that is cell from which all the other lineages develop or differentiate. So mainly acute leukemia is broadly divided into two categories. One is acute lymphoblastic leukemia or ALL, or acute myeloid leukemia or AML. So these are the two broad categories of leukemia. So the names are self-explanatory. Lymphoblastic leukemia are ones which arises from the lymphoblast, and they look like lymphoblasts. They have a characteristics of lymphoblasts, meaning they have the characteristics of the lymphoid cells. And AML is acute myeloid leukemia. It arises from the myeloid progenitor. It characteristics of a myeloid progenitor. Normally, these cells differentiate into different cells of the myeloid lineage: neutrophils, eosinophils, basophils, etc. And the lymphoid progenitors normally differentiate to lymphocytes, B or T lymphocytes. So since these cells arises from this normal cells when they have some abnormality, the acute leukemia also reflects the behavior of the normal cells sometimes. First, we will talk about the general characteristics of acute leukemias. Then we will see how we classify acute leukemias. Then we see how we diagnose acute leukemias using different methodologies: morphology, flow cytometry, cytogenetics, and other molecular genetic techniques. And then we talk briefly about the treatment. Hold on, I'm trying to. So leukemia is a malignant disease. It is a type of cancer, and it is characterized by unregulated proliferation. So unregulated proliferation is the basic characteristic of any type of cancer. The same holds true for acute leukemias also. So of a particular cell type. So the cell type here involved is a blood cell producing cell or a hematopoietic stem cell. It can involve any of the cell lineages or a stem cell common to multiple cell lines. Mainly, leukemias are classified into two different types: chronic leukemias and acute leukemias. So basically, this reflects the basic cell from which they arise or the behavior of the cell. So acute leukemia is rapid in onset. The patient will present to you within days or at the maximum weeks after the disease has started. Whereas in chronic leukemia, the onset is slow and insidious. The patient presents to you many times, even months after the disease has started. Chronic leukemia, the survival is usually longer because the disease is less aggressive. Whereas in acute leukemia, the disease is very aggressive. And if not treated, the patient usually succumbs within days to weeks. And another important feature is the type of cell you see in acute leukemias. You see blasts. Blasts are basically undifferentiated early type of cells, whereas in chronic leukemias, you see more mature cells. Acute leukemia, as we just discussed, is the type of malignant transformation of a stem cell and causing unregulated proliferation. Normally, the stem cells differentiate or mature to more mature cells. Lymphoblasts mature to lymphocytes, myeloid blast matures to neutrophils, monocytes, etc. Whereas in acute leukemia, there is no such differentiation. There is arrest of the maturation. So the cells are stuck at one time point. That is, they all are stuck as blasts. They don't differentiate. So you see a lot of blasts. It's the most immature cell, and usually you see that the cell is committed to a particular line, meaning it can be a lymphoblast or a myeloblast. So how does the patient present in the clinic? Because these cells proliferate, they accumulate in the tissues, leading to different manifestations. These cells proliferate in the liver and spleen and lymph nodes. So you have hepatomegaly, you have splenomegaly, you have lymphadenopathy, etc., etc. And this also can involve other tissue organs like CNS, skin, etc. So that can lead to mass lesions or defecting function in these organs. So there are two different types of blood cancers or malignancy of the hematopoietic system. The term we use for them are leukemia, lymphoma. So what are they? So what is the difference between a leukemia and a lymphoma? So leukemia is when we call something as leukemia when the abnormal cells or the cancer cells are present in the blood and bone marrow. So basically, you see when you examine blood or bone marrow, you see a lot of these cells in the to be present in the blood or bone marrow that we can see by microscopy. Whereas lymphoma is usually abnormality seen in a lymph node. So the cancer cells or malignant cells, they are present and proliferating within the lymph node. So this will result in lymphadenopathy. So when you have a lymph nodal mass, when you see a patient with big cervical lymph nodes, big axillary lymph nodes, that is what you call a lymphomatous presentation or presence of lymphoma. Whereas in leukemia, all these abnormal cells are seen in the peripheral blood. So you have leukocytosis. And when you examine a peripheral smear or when you examine a bone marrow under the microscope, you see a lot of these abnormal cells. So this refers to the type of presentation. So this is not a 100% cut and dried criteria. Leukemias can have a lymphomatous presentation, meaning this type of cells can present within the lymph nodes. And lymphomas, also during late stages, they can spill from the lymph node into the blood and bone marrow. So basically, all these lymph nodes and lymphomas are interconnected tissues. Primarily, they have one type of presentation, but otherwise, they can evolve from one stage to another. So what causes this blood cancer? So what causes this leukemia? There are multiple factors. No single factor has been put forward as the single most responsible factor. There are multiple of factors. This can be related to the patient himself or herself or to the external factors. So what are the host factors or the patient-related factors? So there are some patients who are born with this predisposition, meaning they have something in their chromosomes, something in their genetic makeup that leads to increased cause of cancers. One example is Down syndrome. These patients have a lot of cancers. One of which is leukemia. There can be immunodeficiencies. There can be myeloproliferative disorders or syndromes, which over a course of time can lead on to acute leukemias. And there are some bone marrow failure syndromes, aplastic anemia, paroxysmal nocturnal hemoglobinuria. These all over time can lead on to acute leukemias or related with acute leukemias. And there are other factors which may not be related to the patient himself directly, and these are called the environmental factors. So what are the environmental factors? These are exposure to ionizing radiation and exposure to certain types of drugs and chemicals. These drugs and chemicals themselves have mutagenic potential. So you would have read in the basic pathology what and how a mutagenic potential arises. And also there are certain many different types of viral infections. Most common one is Epstein-Barr virus or EBV. This leads to specific type of cancers. So one important cause of cancer, or which underlies the development of a cancer, is genetic abnormalities or chromosomal changes. So broadly speaking, chromosomal changes are one which involve the entire chromosome, or we can see in the cytogenetic testing. So this can be a trisomy, this can be a monosomy. In this case, the basic underlying genes are affected. So this leads to this leads to disruption of normal activity, leading on to cancer. So the term genetic change or molecular change is used when the change is small, which cannot be seen under cytogenetic examination. You need some other type of directed testing. So when small genes are involved, then it is called as molecular or a genetic change. So both of these changes can lead to disrupted maturation of the cell, and that can lead to cancer. So the common type of mutation seen in TALL is mutation in a type of a gene called Notch1. So this normally this gene is involved in differentiation of T lymphocytes. So when there is a gain of function mutation in this Notch1, so again you would have learned in the basic pathology class about what is gain of function change and the loss of function change. So when a gain of function change occurs in a Notch1 gene because of a mutation, this leads to cancers of that particular lineage. In BALLs or B acute lymphoblastic leukemias, one of the commonly involved gene is a PAX5 gene. So there is loss of function in this gene. So normally this gene is involved in the differentiation of a B cell. So what do you mean by differentiation? So proper development of B lymphocytes from lymphoblasts. So this requires a proper genetic programming. When that is affected, then leads to abnormal proliferation of this B blasts at an early age. So this leads to abnormal proliferation and prevention of maturation. So this is what we call development of acute leukemias. So when we see how many cases are involved, how many cases of acute leukemias have this basic genetic change. So as more and more genetic tests are being done and more better sequencing methodologies are becoming available, we are finding that a great number of acute leukemias, especially ALLs, are having karyotypic abnormalities. So what are these karyotypic or genetic abnormalities? So in BALL is B acute lymphoblastic leukemia. So in this class, for acute lymphoblastic leukemia, we use the term ALLs, and this will be constant throughout the class. And if it's a B lineage, we call it B, and if it's a T lineage, we call it T. So in BALL, the common type of genetic changes seen are hyperdiploidy. So what is hyperdiploidy? So it is increase in the number of chromosomes per cell. So normally we have 46 chromosomes, so 23 pairs of chromosomes. So when the numbers are increased, the chromosomes themselves are the whole chromosomes are present in extra numbers. So this leads to what we call hyperdiploidy. And there are certain types of specific translocations and associated genetic abnormalities. For example, translocation 1221. So it is translocation between chromosome 12 and chromosome 21. So this involves this two specific genes, ETV6 and RUNX1. So this leads to, when there is translocation, there is a specific fusion product. So two genes which are normally far apart in two different chromosomes, they come together, they fuse together and started functioning abnormally. So this type of fusion, translocation and fusion genetic abnormalities underlie blood cancers. So these are recurrent. So we see specific types of abnormalities in specific types of cancers. So this helps us in the diagnosis and prognosis of these cancers. 25% of adult pre-ALLs. So adult ALS, they behave differently from pediatric ALS. So a large proportion of this, about 1/4 of this, have a translocation 922. So in which the genes involved are ABL and BCR genes. So we can one, diagnose these cancers using these techniques. Two, we can understand how these leukemias behave. TALS, on the other hand, T acute lymphoblastic leukemias are associated with transcription factor mutations in the T cell receptor locus. This genetic changes, they activate or deactivate certain genes. So PTEN, it's a pro-growth signaling factor. And when this normal functioning is affected, then this leads to cancer. So in TALs, we see frequently changes with PTEN or CKD2E, etc., which somehow affects the P53 gene functioning. So that is for the genetic, basic genetic changes. So now, as more and more literature and more research are becoming available, we are understanding that a large proportion of the leukemias have some genetic abnormalities as the cause of the leukemia. And they help us in understanding the disease as well as in diagnosing the disease. So how does these patients, the acute leukemia patients, present in the clinic? Meaning, what are the symptoms they have, so that brings them to the doctor. So the symptoms are basically the result of the underlying pathogenesis, which is associated with these leukemias. So what happens in leukemia? The basic pathogenesis is the cells proliferate. So there is a lot of this lymphoblasts. So when these cells proliferate unchecked, they accumulate in the tissue. So normally they are seen in the bone marrow. So when they proliferate too much, they occupy the whole of the marrow. So the normal cells, the other normal cells in the bone marrow, they are reduced in number, or their function is reduced. So because of that, you have symptoms. So what are the cells which are normally present in the bone marrow? So there are red blood cell precursors, there are precursors of granulocytic cells, and there are precursors of platelets, which are called megakaryocytes. So all these normal cells which are present in the bone marrow are affected. So they are being replaced by the abnormal acute leukemia cells, blasts. So what happens when the red blood cell precursors are reduced? So you have reduced red blood cells. So that leads to, that is what we call as anemia. What happens when the normal neutrophil protein cells are replaced? So the neutrophils number is reduced. So what we call neutropenia. So because of neutropenia, so normally these cells protect us against infections, against organisms. So when the cells are reduced in number, we have infections. When what happens when megakaryocytes are reduced in number, this leads to reduced platelets. What happens when platelets are reduced? This leads to bleeding. So all these different manifestations are because of reduction of the normal cells, which are present in the bone marrow. So that is one symptomatology. Other clinical features are when the cells proliferate in the bone marrow, just don't stay within the bone marrow, because they proliferate too much. They just can't be contained in the bone marrow. So second is mass effect. So when the cells proliferate within the bone marrow, they can't be contained within the bone marrow because the bone marrow has become too small to accommodate these cells. So they start spreading over into the other tissues. So they can go to anywhere within the body. So first they start going to the lymphoreticular system. So what does this lymphoreticular system consist of? It consists of the liver, spleen, lymph nodes. So these are cells which are usually home to these hematopoietic cells. So these cells multiply and start getting seeded within these organs. So the liver enlarges, the spleen enlarges, the lymph node enlarges. So the patient has splenomegaly, hepatomegaly, or lymphadenopathy. So they can present with organomegaly or lymphadenopathy. Because the bone marrow expands, the bone expands. And when the bone expands, there is expansion of the peria as well. So because of this, the patient has bony pains. Another common presentation of TAL, acute leukemias, is as a lymphomatous mass within the mediastinum. So the patient has mediastinal masses or masses within the abdomen. The lymph nodes can enlarge and compress the normal organs. They can go and sit within the central nervous system. That leads to headache, vomiting, seizures. Males, the pancreas side, or side where these cells are present is the testis, so leading to testicular swelling. When we examine the peripheral part of bone marrow, we have one is anemia, thrombocytopenia, which we normally see, in by doing a routine blood examination. The WBC count can be depending on I think that's one person when you do it. Just keep your mic on mute. Yeah, so we're talking about the peripheral blood count. One is anemia and thrombocytopenia. Second is the WBC count. The WBC count can be high. When the blasts proliferate, they can, come spill over to the peripheral blood, resulting in increased WBC count. In that case, we will see a lot of blasts in the peripheral. So this is called a leukemic presentation. There is something called a leukemic or subleukemic presentation, in which actually the WBC count is reduced. Why this happens? Because the blasts proliferate and stay within the bone marrow only. They don't come out to the peripheral blood. So in this, you diagnose only when you do a peripheral, when you do a bone marrow examination. So peripheral blood test alone cannot tell you the diagnosis. In all cases of acute leukemia, usually we do a bone marrow examination. The bone marrow is hypercellular, meaning there are a lot of cells within the bone marrow. And as you have rightly guessed, the increased number of cells is due to increase in the blast cells or the early hematopoietic cells. And the normal cells, the normal erythroblasts, the normal granulocytes, the normal there is somebody in the background who is not on mute. A lot of noise coming. So you have to remember that normally also the bone marrow can have blasts. So for acute leukemia, you have to have increased number of blasts, and the cutoff is 20%. So at least you should have 20% in the 20% blast in the peripheral blood or bone marrow, or both. The lab test which we do to diagnose this acute leukemias. So the patient has come to you. He has anemia, thrombocytopenia. He has enlarged liver and spleen. So how do you diagnose this? So we do certain lab test after doing the clinical testing. So you order a complete blood test, and then you can confirm anemia and thrombocytopenia, and then you look for a peripheral smear examination. You see a lot of blasts, and the bone marrow examination is done. Bone marrow again will show increase in hypercellular bone marrow, increase in blasts, and reduced normal hematopoietic elements. So in the bone marrow examination, you can do an aspirate. Aspirate is basically checking the liquid bone marrow. And biopsy, you can do a core biopsy, take out a piece of bone, and then you can do different tests on it. And you can do cytochemistry. We'll come to it, what is meant by cytochemistry. We can do other tests like flow cytometry, cytogenetics, and molecular genetic studies. So flow cytometry tells you what type of immunophenotypic type of acute leukemia it is, whether it is acute lymphoblastic leukemia, myeloid leukemia, and whether it is BALL or TALL. Cytogenetics and molecular genetics tells us the basic genetic abnormality. So we have seen that broadly it's classified into acute myeloid leukemia and acute lymphoblastic leukemia. Myeloid leukemia, it includes myeloblastic, erythroblastic, macrocytic, etc. Whereas ALLs or acute lymphoblastic leukemia includes T and BALLs. So if you look at the incidence of this ALL, it is usually more common in children, and AML is more common in adults. But this is a broad categorization. It doesn't mean that ALL can't occur in adults or AML can't occur in children. So both of the cancers can occur in all age groups. But the common presentation is ALL is common in children, and AML is common in adults, especially in older adults. So we'll talk about some salient features of ALLs. We know that it is classified into B and T ALLs depending on the type of cell of origin. A large majority, about 80 to 90%, are BALLs. So that is the most commonest type of ALL. And TALL is usually less common. So it is 15% total. So how does this lymphoblast, which is the basic cell which is causing this ALL look like? So it is a medium to small sized cell with the scant cytoplasm. So the cytoplasm is less in amount compared to a myeloplasm. The chromatin is dense. The nucleus is not, the nucleoli is not distinct, and the structure called OR rod is not present. So when we look at the B cell maturation, so this is the progenitor cell of the lymphoblast, early lymphoblast. It leads on to this differentiated lymphoblast, which leads on to normal mature cells. So the cancers can arise from each stage. So when the cancer arises in the early stages, there is progenitor to this early B cell stage that leads to acute leukemias, and this also can be classified as BALL, pre-BALL, etc. So once the cell matures into a lymphocyte, when a cancer arises from the mature cell, which is chronic leukemia, it could be CLL, HCL, etc. We use different classification systems to classify this type of cancer. So it's important to classify, one, to understand what type of cancer it is, and second, for treatment. So each type of cancer has a different type of treatment, and differentiating them at the baseline is important to choose proper treatment and to understand how the disease will behave. Some diseases will behave very aggressively, so you can treat them aggressively. Some leukemias will behave in indolent way, so you can treat them in that way. So Eagle cell classification is one of the earlier classifications which was used to classify BALLs and even TALL. So this classified into Pro B, Common B, Pre, and Mature B, depending on certain immunophenotypic markers. So these are certain markers which are present on the surface of the cell. We'll come to it in a while when we study the flow cytometry part. T classifications, it's classified into Pro, T, Pre, T, cortical maturity, depending on the certain markers. So when we do flow cytometry, so how are these markers identified? We do tests like flow cytometry and immunohistochemistry to identify the markers on these cells. So when we do this, presence on the positivity or negativity, so whether these markers are present or absent, we classify this tumors into different types. We'll come to it, how we do it. So Eagle classification was an older classification. So nowadays we follow WHO, World Health Organization classification of tumors for different tumors. So for blood cancers also, for leukemias also, we follow WHO classification. So this classifies based on the clinical features, based on the blood counts, based on the morphology, based on the flow cytometry and other genetic markers. So here the main categories are BALL and DALL, and again inside the BALL, there are different types of entities. So what the main differentiating feature between these entities is presence of a specific genetic abnormality. So translocation 922 is one subtype. Translocation 1221 is one subtype. So in the subtype, there is abnormality of this two genes, CTV6 and CONNEX1. So there is BALL with hyperdiploidy when the chromosomes are higher than what should be normally present in an individual, or hypodiploidy and the chromosome number is lesser than what should be present. In BALL, so the classification initially was into L1, L2, and L3. L1 is most common. The cell size is fine with clump chromatin. In L2, it is a little commoner in adults compared to children. The cells are slightly larger compared to L1. Here, usually we can see a prominent nucleolite, and the cytoplasm can be little more in amount compared to the other one. So L3, now the L3 is classified into something called the Burkitt's leukemia lymphoma. This is less common compared to the other two tumors. So next, so that is for acute lymphoblastic leukemia. In acute myeloid leukemia, we do all these different types of tests to identify the disease, to classify the disease. We will do a bone marrow testing, we'll look at the cells under a microscope, we do cytochemical testing, we do other special tests like flow cytometry, cytogenetics, etc. So how do we classify this AML? So we saw how did we classify the ALLs based on EP classification, based on WHO classification. So the most common the classification of AML followed is a very simple type of classification, which is present in the 70s and 80s. So this is called the FAB classification. So FAB is French, American, British. This group made a classification in the early days, 70s and 80s. And this is all followed through till this day because it is simpler classification based on simple tests available, and it is one of the widely accepted classifications. So it is classified into 7 different types. So M1 through M6. So M1, M2, M3 till M7. So what is this M1 to M7 mean? So each indicates a specific type of lineage. So we'll come to that in a bit. And also that system is little outdated. It does not take into account the modern advances in science. So we nowadays again have another WHO classification for AML also, like we had for ALLs. So this again classifies into different etiologies, like it could be therapy related or it could be related to a chromosomal translocation. So we saw that translocations and genetic changes are basic causes of cancers. So again, we have AML with translocation 821 with fusion of this gene, RUNX1 or RUNX21. We have AML with mutated NPM. So these are AMLs or acute leukemias classified based on the different genetic abnormalities. And this AML with translocation 50 something. So this is acute promyelocytic leukemia. It's a very big list of all the different types of acute leukemias. So what is the basic morphology of myeloblast? So it appears a little different from lymphoblast. As you can see, they have characteristically pink rod-like structure within the cytoplasm. So this is called an R rod. So presence of R rod indicates that it is a myeloblast. So again, you can see a case of AML where you have this large blast. So compared to the lymphoblast, the cells are much larger and they have abundant cytoplasm. The lymphoblast, the cytoplasm is very less in amount. Here you can see that the cytoplasm is abundant. surrounding the cell, and you have a small thin rod-like structure within the cytoplasm. This is called the R rod. So this is AML M1. So AML M2 is acute myeloid leukemia with maturation. So here the blasts are more than 20%, but in addition to the blasts, you can see these differentiated cells. So what are these differentiated cells? These differentiated cells are neutrophils. So we can see a lot of neutrophils and myelocytes in addition to blasts. And the third important category of AML is AML M3. So the other name of AML M3 is acute promyelocytic leukemia, or APML. So how does this APML differ? So it's a specific and important type of AML. It has a very aggressive course. So if not treated within hours, the patient will die because of bleeding. So this is a rapidly proliferating disease. And you can see a promyelocyte. So all these are promyelocytes. This is a classical promyelocyte. So in other type of AML, we see just one R rod. So if you see here, the whole cytoplasm is packed or stuffed with R rods. So this is what you call the fagot cell, where you have a lot of stuffed up R rods. So this specific subtype of AML, acute promyelocytic leukemia. Also, if you see, the nucleus here is not round; it is sleeved, and we have this typical bilobe nucleus. So this is also again characteristic of APML, or acute promyelocytic leukemia. This is a very aggressive disease which leads to a lot of bleeding manifestations, and the patient expires very fast if the treatment is not started early. Fourth type is acute myelomonoblastic leukemia. So, monocytes are normal cells present in the peripheral blood, and they'll arise from the progenitor called monoblast. So, when the cancer tumor involves the monoblast, we can get myelomonocytic leukemia or a monoblastic leukemia. So, this is M4 and M5. So, M5 is acute monoblastic leukemia. Here, the cell of origin is a monoblast, which normally give rise to monocytes, whereas in a leukemic type of scenario, when there's a cancer arising from the monoblast, it leads to acute monoblastic leukemia. And this usually has a specific type of presentation in that it infiltrates the extramedullary sites. So it can go and sit in the gums, it can go and sit in the CNS, and present as a big mass lesion. So you can see, there is gum hypertrophy, there is, lymph node enlargement, there is presence of this mass deposits, leukemic deposits within the CNS, etc. Another type is M6. So this is erythroleukemia. This is a very rare type of AML where you have involvement of erythroblasts. M7 is involvement of megakaryocytic lineage. So it is called acute megakaryocytic leukemia. Coming to the lab investigations, once we have seen these cells under the microscope, we do certain special tests. So one is a cytochemistry. Cytochemistry is basically you use certain special techniques on the slide to see what type of cell or lineage the blast belongs to. So we commonly use a stain called myeloperoxidase staining. So myeloperoxidase staining identifies the myeloid cells. So if it is positive, it is called AML. If it is negative, it is called acute lymphoblastic leukemia. Sudan black is a similar type of stain. And another type of special stain or cytochemical stain is non-specific esterase. So non-specific esterase is present within the monocytic cells. So if it is positive, it is AML, M4 or M5, where you can see monocytic blasts or monoblasts. Acid phosphatase is present typically in the T lymphoblastic leukemia. So you can see this reddish dot-like structure within the blast. So mainly you do MPO to say whether it is a myeloid or a lymphoid lineage, NSE to say whether it is a monocytic or non-monocytic lineage. So once that is done, you do a flow cytometry. So what does flow cytometry do? So what is flow cytometry? Is a special type of test where you add certain antibodies to identify certain markers or molecules present on the surface and cytoplasm of the blast to identify what lineage it belongs to. And you can count the blasts and you can assign the lineage. So we won't go into the technique. So this is one of the plot where you have this CD45 written here. So it means it is a plot to identify the CD45 marker. So it tells us whether the CD45 marker is present in the cell or not. Here we have CD34 written, so it says whether the CD34 is present in the cell or not. So CD45 is a marker seen in all hematopoietic cells, but in leukemias, in blasts, the CD45 is slightly weak. So not just the presence or absence, you can identify the intensity also. And the blast show immaturity markers. So what are immaturity markers? Immaturity markers are 34 and TDT. These are markers which are present in the very early stage of the cell. As the cell matures, the markers are lost, the masses decrease. So when this immaturity markers are present, you can identify that a particular cell is a acute leukemia cell. So you can say this is a red population here. This is a specific type of population. You can see the 45 is dim, and you can see the 34. 34 is present on the y-axis. Y-axis it is positive. So this is a blast population. And in addition to the immaturity marker in CD45, you can do other markers to identify the lineage. For myeloblast, you can do 11B, 15, 16. For B and T lymphoblast, you can do CD3. And then for B lymphoblast, you can do other markers and their absence. So what are the lineage-specific markers? For myeloid, it is MPO. For T cells, it is CD3, present within the cytoplasm, the small c indicates cytoplasm. And for B cells, you can do CD19, CD10, CD17, NES, etc. And for T cells, you can do CD3, CD7, CD2, CD1A, etc. For myeloid, you can use CD13, CD33, etc. So when this particular tumor has CD19 and CD10, then you can say that it's a B acute lymphoblastic leukemia. So here we can see a case of AML where you can see this red population, which is showing CD34. So CD34 is a marker of blast. And then you can see they are positive for 117 and they are positive for CD13 and 33 and HLA. So all these are myeloid markers. So this is a case of AML or acute myeloid leukemia. So again, this is another case. You can see that there are a lot of the similar looking cells. All are very large cells compared to the RBs. They are at least 2 to 3 times bigger. And they don't have any R rods. They are basophilic cytoplasm. And when you see the flow plots, you can see this red population here, which is present in the blast window. And it is positive for CD34. So CD34 is present on the y-axis. All the cells show CD34. So it indicates that it is a blast. And they're positive for CD19. They're positive for CD10. Here, CD10 is present on the y-axis here. CD19 is present on the x-axis. So it's positive for CD19, 10. It's positive for CD22. So it all indicates that this is a cell belonging to the B acute lymphoblastic leukemia type. This is another case where you can see the red population is positive for CD5. CD5 is a T cell marker, and it is present positive for CD7 and 2. So this again is a T cell marker, and it is negative for 19. So 19 is B cell marker, it is negative for 19. So it is not a B cell lineage. So this is how you identify based on the markers the particular type of leukemia. There are some leukemias which are rare leukemias, which have a mixture of these markers. We call them mixed lineage leukemias. And another test we use is cytogenetics. So cytogenetics is basically looking at the chromosomes to see whether the chromosomes are increased or decreased in number, and whether they are structurally intact or there is abnormality in the structure of the chromosomes. So this is a normal chromosome typing where you can see the chromosomes are arranged from chromosome 1 to 22. So you can see that there are two chromosomes, number of chromosomes for each type. So we have this total 46 chromosomes. So chromosomal translocation is one when the genetic material between the chromosomes get exchanged. So this is chromosome 7 and 8. So normally they are genetic material 7 is present within 7 only. When there is translocation, there is exchange of this genetic material. So we diagnose the cancers based on the cytogenetic characteristics. Next is prognosis. So you'll have to tell whether the acute leukemias will behave very aggressively or will behave favorably. So what are the clinical characteristics? So poor prognosis is when the cancer occurs within less than 1 year or more than 10 years. Between 1 to 10 years, the prognosis is favorable. And when the WBC count is very high, that is more than 50,000, it is poor prognosis. When it is less than 50, it is good prognosis. So there are other different characteristics in AML based on the cytogenetics. So that is why we do cytogenetics to understand these diseases. So how do we treat these diseases? So broadly, it is based on chemotherapy. So we give drugs to control the proliferation of these cancers. And in recent times, we don't use single drugs, we use multiple drugs. We use combination of drugs. So what we call combination chemotherapy. This is because the acute leukemia cells are very aggressive cells. So we need different types of drugs which can target different pathogenesis behind it. Nowadays, with the advancement of understanding of the disease, we target specific molecules. So what we call targeted therapy and immunotherapy. Certain leukemias like AML, they are very aggressive. So many times we need a bone marrow transplant in which we give chemotherapy, knock off the whole bone marrow, and then we replace it with the bone marrow from another person. So that is called bone marrow transplant. So that is also used in specific type of cancers. And for APML, acute promyelocytic leukemia, which is a specific subtype of acute leukemia, which we saw, which behaves very aggressively, we use all transretinic acid and retinol. So I think I will complete here. So somebody wants to ask anything, any questions, or if you can either unmute yourself and ask, or you can chat in the chat box. That is also fine. So, okay, if there are no further questions, we will end the class. So, thank you.
Sir, have you taken the attendance?
Yes, sir, I have taken the attendance.
Okay.
Good morning, sir.
Good morning, Ganesh. Thank you very much.
Thank you, sir.
Okay, thank you all. So, we will end the session now. Thank you.
Sir, practical class will be held through same link, right?
You guys are joining so late and now you're typing the attendance. Who is this Lohitashi?
Sir, I joined since 8 o'clock. I have
Why are
written
you
the
typing
attendance at.
again? Why are you typing again then? You have been marked present
Sir, I
already,
thought,
no?
yeah.
तो क्यों दोबारा लिख रहे हो यार?
No, for
There's no need,
practical
okay?
class. Practical class 9 p है ना, यहीं पे है.
Okay, this is for class 9 to 10 a.m. you're writing.
या practical class अभी है ना,
Okay,
इसी
तो
लिंक में है.
अभी तो 9 भी नहीं बजे यार, अभी 9 तो बजने दो पहले.
ठीक है सर.
चलो, I have marked you already. Your next class is a practical class, no? Anyone?
Yes sir, practical class अभी.
Okay.
सर वो practical class LT1 के थ्रू ही होगी ना?
क्या चीज?
वो practical class कैसे होगी? वो LT1 के थ्रू होगी या मैम अपने वहां से करेंगे?
यार actually ना I'm also the Eugene class in charge for the first time. I think इसी के थ्रू होना चाहिए. I'll ask sir once के link अलग से बनेगा या फिर
जी राहुल सर ने कहा था.
हाँ?
राहुल सर से
No,
पूछ
no,
लेता हूँ.
Rahul sir is not the in charge now. I am the in charge अभी.
ओके सर, आपका नाम क्या है?
साथ.
ओके सर.